Welcome everyone to the Aspirational Healthcare Conference. I'd like to share a story that I think helps frame my perspectives as it relates to this critically important area. In April of 2018, I was working as a consultant, helping to lead kind of a jumbo employer national practice at one of the major consulting houses. And I had the chance to go and visit with the leadership at Google's headquarters. And on this day, I was headed to the location. I was in my suit in the back of an Uber and driving, and I was a little bit nervous. I was excited to be able to go because you hear about how great their headquarters is, and I had never visited before. And the driver asked me what I did for a living. And I told her that I work within healthcare as a consultant. And she said something amazing to me that I had never heard in the wild. She said, "Oh, I love my healthcare. I love my healthcare. And I'll never leave my current employer as long as I can keep it exactly how it is right now." This was interesting to me because she was moonlighting as an Uber driver. It was during spring break, and so I learned that she worked for a school district there, and that she was taking some extra days during vacation to earn a little extra money. And I then, of course, leaned forward and I told her that. I said, "I've never heard anybody say that before, just out in the United States. What is it that you love about it? What is it that makes your healthcare amazing that you would say that?" And I'm going to tell you what she said, but I wanted to pause for 1 second and issue that question to all of you. What do you think that she said? What do you think she said? I want you to take just a second and jot it down. Come away from your email for a minute, okay, and focus here. So I'm in the car. She says, "I love my healthcare so much that I won't leave my employer because I don't want to lose it." Never heard that before. I asked her why she loves it. What is it that was special about her program? What is it that she said? What is it that makes what I would call an aspirational healthcare program? Give you another 8 seconds. Okay, great. So here's what she said. She said, well, for one, it's affordable. If I need to go to the doctor, it only costs me $10 or $20 to be able to go and see my doctor. Second, my doctor knows me. I feel like he listens to me, he knows my children. And I know that if something goes wrong, he'll know where to send me so that I'm going to be okay, so that I can go to a really good doctor to help me, to take care of me. And finally, what I really love about it is that if something goes wrong, I know where to go. If I'm scared, if I'm sick, I'm nervous, if one of my kids is sick, I know exactly where to go. And I sat back in my chair there in the back of the car, and that was and it was a moment of reckoning, because I realized I was absolutely grossly overpaid. It's like, of course, that's exactly what makes amazing healthcare, right? A great relationship with the physician, having trust, knowing where to go, and having it be affordable. Now, by show of hands, how many of you had something similar to what I just shared written down on your own sheets or scratch pad or notes or whatever? I actually can't see your hands, but hopefully you're getting a little hand raising exercise. Yes, that's exactly right. And that's what I realized too. I'm like, well, that's silly. I know what great healthcare looks like, so of course that's what she has. And it doesn't take a consultant or anybody special that focuses on healthcare or is a policy wonk to tell you what makes great healthcare. We all intuitively know what aspirational healthcare looks like. But just because we know what we want doesn't mean that we know how to build it or that we know exactly how to get there. And that, to me, is what's exciting about this conference, is that we have the opportunity to come together today and tomorrow to learn how to get there, even though intuitively we do have a sense, of sort of kind of North Star of where we would want to be and what we would like to have. And this is about charting the journey to be able to be successful. Now, of course, the question becomes, well, where do you start, right? Because I know what we have now and I know what I'd love to have, and there's a pretty wide gap there. Well, the concept there is that we look at the gateway to healthcare, which I would characterize as the place where we get our primary care. That has been a central focus in lots of places. The primary care really is the heart of the industry. Good primary care being what we would seek to have. And the problem is that good primary care seems to be under assault. And I would say that good primary care necessarily includes an alignment of incentives between the primary care provider and the patient. And anything that disrupts those incentives starts to erode the value of primary care and puts at risk its ability to deliver a promise that is truly aspirational. The reason this is challenging is because primary care is being gobbled up everywhere in the country, whether it be by health systems that are paying outrageous sums to acquire primary care practices, to insurance carriers that either through negotiations or contracts or outright purchases are buying up primary care as well. And the only reason any of these entities would pay astronomical prices, much greater than the dollars and cents would indicate, is because they're not buying the primary care practice for the joy of providing primary care. They're buying the primary care practice for the joy of being able to profit through the referrals that come from it, which is misaligned with the incentives of patients who want to consume the least amount of care at the lowest cost they can in order to stay healthy and well. It's funny, I actually was a bad student in this area. I'll be the first to admit it. I used to look at direct primary care, for instance, as an area that is safe, that does align the incentives of the provider and the patient. And even while independent primary care has been getting acquired and gobbled up, good, safe, direct primary care has been increasing significantly. So there is a great answer that is sort of coming more and more into the mainstream. But I looked at it and always used to think, well, I'm only spending, a couple $100 per year on primary care today, but direct primary care costs like 2, 3, in some cases 4 or more times more than what I'm paying today. I can't get over that. And I was always sort of negative on it. I was not a believer. I thought we can use what's there and just be careful about steering right. Until one day I was having a conversation with Daryl Moon, who is the organizer of today's conference. And, I sense he wouldn't admit this, but he was a little frustrated with me because I had been a bad student for many years in these conversations. And I was like, I'm not sure about this. And he said, look, Lee, what we know is that a relationship is important with the provider. And I said, absolutely. I think it's important that people have a relationship and that incentives are aligned. Absolutely. And I'm like, and there's plenty of independent primary care. Well, at least there's a lot still left. We don't necessarily have to go to direct primary care. And he said, well, what we're getting at here is how many people actually go to primary care? And I said, admittedly, only about half. He said, that's right. About half of people, I'm paraphrasing, will go to primary care, but the other half, primary care has to come to them. And there has to be a way for us to compensate the outreach that must occur to reach about half the population who won't voluntarily, for whatever reason, hop into primary care. And he said the goal isn't just to have a provider there when you need it. The goal is that for every person, they have a relationship of trust they can rely on when things go wrong. He said, Lee, have you ever known anybody who was related to a doctor And of course, I said, well, yes. In fact, I can personally identify with that. My mom was a triage nurse, not quite a doctor, but she was really good at handling the vast majority of what we would have needed, right? Or what would be scary if something went bad with our healthcare. And he said, great. So what is it that changes in your behavior when you know a doctor, or in this case, a nurse? And I remember to my street growing up that on this street we didn't have a lot of money, and none of the other families on the street did either. And I remember that my mom was sort of the de facto healthcare provider for the entire street. I remember on one occasion, Adam Starker, he lived near us. Their family, the father had become incapacitated. They didn't have a lot of money, and they had 9 kids. And Adam had fallen and gotten a rock lodged in his forehead. And his mom was, beside herself and came running down the street to our house. And I remember sitting there in the living room watching while my mom sort of got out all of her kits and was able to remove this stone out of poor Adam's forehead. And he was totally fine, and everything was good thereafter. But that was something that for the Starker family, my mom was their trusted outlet to healthcare. And Daryl said, don't you think that every person in the country should have that? And he was right. Everyone should, and everyone deserves that you have someone you know and trust who's affordable and excellent, who can help you to get the outcomes that you need. And that's going to be what we are looking at and working on building and learning how to create, generate, and offer during the next 2 days. A couple of housekeeping items. The way that the conference is organized is around a number of sessions. Keynotes, of which there are 3, and those are live with Q&A at the end. Track presentations, of which there are 8. And you'll be able to 2 on the first day and 2 on the second day, up to 4 of them. Half of that, some of it is recorded, and you'll be able to review those that you don't get to during this conference after the fact. But the latter half, where I think the best learning occurs, comes through the Q&A, which is live. So make sure that you attend 4 different breakout sessions. And then finally, discussion groups will occur at the end of day today, early tomorrow, and at the end of the conference tomorrow. And again, there I think is where the critical opportunity comes in, of being able to discuss with peers what we've learned and find ways to make new connections, not just of knowledge, but also with peers who are aligned. So make sure to be able to attend those. Secondly, if there's any problems with technology, on the homepage there is an email and a phone number to Rosellen. She's able to help with any issues that come up. And so look for that. There's also a feedback email going out at the end of each day. It'll take literally 30 seconds to be able to reply to it, give a rating, and provide a comment if you desire to do so. There's a welcome video on the conference, also on the homepage, with our conference host, Daryl Moon. And finally, we want to express a special thanks to the Southcentral Foundation and the Nuka system, inspiring us with this amazing healthcare delivery system that they have built, and providing an example for all of us to be able to follow. They have been so supportive in helping really to put this conference together. And a special thanks also to Tanya Oden at the Southcentral Foundation Learning Institute for her work in helping to put the conference together. Also to mention our excellent conference sponsors, the platinum sponsors being Sedera with medical cost sharing as a program for managing large healthcare costs and claims, and Your Heart Test, which is state-of-the-art testing technology for heart. Gold sponsors being HCRM, the Healthcare Predictive Analytics Company, Resilience Pro around proactive mental health, and the Health Benefits Lab, the online community for controlling costs and improving health. The silver sponsors are the Smith Communication Partners, a management consulting firm specializing in employee marketing and corporate communication. Blomquist Hale, that has a high utilization employee assistance program. And of course, Orion with the population health program. Finally, our bronze sponsors of Medisync, NFP, Redirect Health, Patient Pal, the Relentless Health Value Podcast, Going on Offense, Integrated Musculoskeletal Care, and Spangler Associates. Wanted also to express appreciation to the American College of Preventive Medicine for what they've given to this conference, and wanted to give their president, Dr. Tonette Krauselwood, a couple of minutes to introduce the college. And with that, over to Dr. Krauselwood, and then you can stay where you're at, and we'll go into our first keynote with the Nuka Foundation, or with Nuka.
Thank you. Thank you so much for the opportunity to speak with this impressive audience today and to share a few perspectives about a unique opportunity to support transformation of our healthcare system to address the ongoing and emerging clinical and public health challenges we all face. As a board-certified physician in preventive medicine and president of the American College of Preventive Medicine, which represents over 2,000 physicians nationwide, I wholeheartedly support a preventive medicine foundation in the forefront of healthcare. I have experienced the benefits of this approach, and I've also seen the consequences when prevention is on the sidelines. As we are all well aware, the experiences of the past 16 months with the COVID-19 pandemic shined a bright and intense light on the fractures in our healthcare and public health systems, but also the opportunities of our health systems to build health resilience in the people we serve, to ensure health equity, and to reduce the health disparities through a renewed commitment and investment in prevention, particularly for chronic diseases. There is currently increased attention on public and population health, coupled with a call to action to realign our investments in our overall healthcare infrastructure that support in community engagement with implementation of evidence-based prevention strategies and to build a strong public health workforce, all signaling the enormous potential for healthcare organizations to transform their approach to improving health by focusing on healthy behaviors, prevention, and wellness. You know, as I look at the agenda and for the conference over the next 2 days, I see the experts in many facets of value-based reimbursement and evidence-based interventions addressing the leading causes of death and disability. They will present innovative approaches to ensuring good health outcomes and sustained health throughout the lifespan of an individual and across population, with an eye towards higher quality and reduced financial cost. As you hear the presentations, I hope you will be inspired and also see the opportunities in your organizations to engage preventive medicine physicians in addressing your challenges and in identifying solutions. Preventive medicine physicians receive formal training in biostatistics, epidemiology, health systems, population health, and the science of chronic disease prevention, infectious disease mitigation, and emergency preparedness and planning. So health systems, hospitals, and large employer groups such as yours are gaining new knowledge and understanding of the skills, the expertise, and the overall acumen of the preventive medicine specialty. It is my hope that more doors will open to enable residents in our field to rotate through your offices and health systems to enhance the training and the preparation of the next generation of these physician leaders so that they are best prepared to help you and your organizations address the real-world challenges. In addition, our board-certified physicians can add value as employed members of your team and support innovative strategies to improve the health of your employees and your patients with the goal to build health resilience in our communities locally, nationally, and globally. So I thank you for the opportunity to greet you all today and to wish you the best during this conference and always. Thank you.
Thank you so much. We are now going to have the opportunity to begin with our keynote, spotlighting Nuka and the Southcentral Foundation. Our speakers are going to be April Kyle, the President and CEO of the Southcentral Foundation, as well as Dr. Douglas Eby, the Southcentral Foundation VP of Medical Services. And thrilled to be able to bring you here today, and we'll begin from there with your presentation, followed by some Q&A.
Sounds great. Thank you very much, Lee. We'll start with introductions. My name is April Kyle, and I am Alaska Native, Athabascan, and Russian on my father's side. That means I'm a customer owner in our healthcare system. I've had my babies here, and so I'll speak to our system both as a leader and also as a customer owner who uses our system. Doug, do you want to introduce yourself?
Hi, Doug Eby. I'm a physician executive. I've had the incredible privilege of working here and partnering in support of Alaska Native people and their journey to transform healthcare for 30 years, particular position for 26 years. And it's my incredible honor to join April in telling you our story.
Perfect. So we had a chance to chat with Lee before the session, and I just have to say, the topics, Lee, that you brought up in your introduction are really going to align with what we're doing in our healthcare system. I'm excited about that. It feels like we are in shared space in how we are thinking about healthcare transformation. We have a slide deck. Doug and I are sort of going to take turns sharing, and our plan is to share for maybe 40 minutes and then leave a bulk of time for questions. And I just want to appreciate Lee, who's going to watch for those questions and track them and then shoot them our way at the end. So next slide, please. You might be wondering why this little healthcare system in Alaska is the example that you're looking at today. In some of our presentations, we have slides and slides and slides of data, but we thought we'd start with just one sort of so what slide. So our story is about sort of whole system healthcare transformation. And as we've walked through this journey, we've experienced significant decreases in ER visits and inpatient visits. We have 97% customer owner satisfaction, and that's really important to us, as you'll understand when we share our story. 95% employee satisfaction, and then just around HEDIS measures, which are the sort of comparable healthcare outcomes measures. When we started this journey, everything you hoped to be high on, Alaska Native people were low on, and everything you were supposed to be low on, Alaska Native people were high on. And we've been on a journey to redesign our healthcare system, and it's resulted in our outcomes being sort of best in class, all at the 75th percentile, and many now at the 90th percentile comparators nationally. Next slide, please. I want to do just a minute of sort of context and history so you know what we're about. So Alaska Native and American Indian people have experienced sort of harms in our wellness as you understand our story and the colonization of our continent, right? And as sovereign governments, we have the right to enter into treaties with the US government. And one of those says that the government will provide, in exchange for the lands and resources we've lost, health care to Alaska Native people and American Indian people in perpetuity. And the way the government began to accomplish that was by creating a branch of the government called the Indian Health Service, which opened hospitals and clinics and started delivering care. And that care was how I received health care as a kiddo. And it was not designed to meet population needs. And Congress actually recognized that that healthcare system was causing even more harm and decided that Alaska Native people could, American Indian people could, choose to operate their own healthcare systems. And the congressionally appropriated dollars that are the seed money for that healthcare could be contracted, and we're part of that story. So we are Alaska Native people who are operating our own regional healthcare system that is owned by and driven by the voice of people, families, and communities. And because that's our design in setting ourselves up, the result has been something that looks, we think, remarkably different than healthcare in the rest of the US. Next slide, please. A key part of understanding our system is this word we use called customer owner. So you are probably used to, when you receive your health care, being referred to as a patient or a client, maybe a member is a word that your insurance company uses. And to us, all of those words reinforce the traditional hierarchy in healthcare. So there's this hierarchy in healthcare that says that doctors and healthcare systems and insurance companies really run the show, and that people and families just come in sort of as recipients of something. And for us, we're really looking to challenge and break that hierarchy. And so we want to create a relationship where we sit in partnership and walk together. And we say, thank you, doctors and healthcare professionals, for bringing your expertise. Please sit in relationship and partnership with aunties and uncles and mothers who also bring their expertise to that relationship. And the word customer owner to us helps us frame that. So words matter, and the people who come in to receive care in our system are both the customers in the system, and at the same moment, they are the owners of the healthcare system at large. Next slide. So we have this set of goals, which are sort of the values of our healthcare system. And before I talk about these goals, I just want to share with you how we think about our vision and our mission. So our vision is a community that enjoys multidimensional wellness, physical, mental, emotional, and spiritual wellness. We think those things are interrelated, that they're connected to each other, and that there is this false notion in healthcare that we're going to take care of the physical wellness, but don't worry, because there's behavioral health. It's in a building over there for that one uncle in your family, and you can go there at 2 o'clock on Tuesdays. And that separation of mind and body, we think is just incredibly harmful. So we imagine that the healthcare system's job is to understand that wellness is multidimensional. And then how you get to that multidimensional wellness is by sitting in relationship and in partnership at a macro level between healthcare system and community, and at a micro level between care teams and families. So we accomplish those through these 3 values that you see on your screen. The first is shared responsibility. We value working together with the individual, the family, and the community, honoring the dignity, and seeing the journey of wellness being traveled in shared responsibility. So really breaking how you would normally think about the orientation between community and healthcare as one of hierarchy and changing it to one of partnership and relationship. We have commitment to quality. We think we can create the best healthcare system in the world. And then finally, family wellness. We see the family as the heart of Native communities. And our system is about more than just diagnosis of illness. It's more than treatment plans. It's more than prescriptions. It's about that last phrase, physical, mental, emotional, spiritual wellness in individuals, families, and the community. And I just want to sit in this for a minute. We think that healthcare far too often sees its role as providing physical wellness to individuals. And I talked for a minute about multidimensional wellness, physical, mental, emotional, spiritual, but we also think that each of us is part of a family. However you define your family, if you've got a set of roommates, that might be your family. And your wellness is interconnected. And so if you believe that, it changes how you design a healthcare system. Next slide. At the beginning of our journey, when we transitioned from this government-operated system and we gave control to community, community was going to run the system, we asked community, what do you want out of a healthcare system? We interviewed patients in waiting rooms. We interviewed people who worked in the system, elders, youth. We did focus groups. We partnered in a research study around this. And these operational principles are what we heard. What does it look like if you could create a healthcare system for your family that would deliver to you what you believe you need? And it's things like that the relationship between the customer, owner, family, and provider should be fostered, whole person wellness, locations that are convenient, access that's really easy, working together, whole system design, outcomes measures, and you can sort of see this list. And this became our marching orders. Now, our system recognizes that there's no right way to deliver healthcare. Instead, the right way to deliver healthcare is to create the competency of listening to community and allowing community to drive what that healthcare system looks like. And we did that sort of once in the beginning, and then we do that continually over time, so that the system that my kids need and my grandkids will need will be delivered because they will be in charge of directing how we're innovating in generations to come. And that's a core competency of our healthcare design. Next slide, please. So we create this idea of core concepts. We talk a lot about behaviors, like how do our behaviors impact our wellness? Well, core concepts for us is about our behaviors within healthcare, within the organization, within the delivery system. So if I was to walk into a clinic and be able to be invisible so that nobody notices that the CEO has walked in, I would look to see people who are working together in relationship, encouraging understanding, listening, laughing, noticing, engaging, sharing. And it doesn't say people are, producing high volume services and meeting sort of revenue targets. It says that we're together as humans in a real and genuine way. Core Concepts is also a 3-day training that's led by me for every new cohort of employees, where we take this idea of sitting in relationship, care team relationship with family, and we start to practice that. We start to, it's based on the idea that relationship is developed when we're comfortable enough to be real with each other. And if I can open up a piece of my heart and share part of my story with you, and you can receive that in a healthy way and share part of your story with me, that connection that we've created as we share that story is the foundation of a real human-to-human relationship. And we can start to value each other. I, as a mom, can value your expertise, and you as a provider can value my expertise. And we want that to be the core of how we recreate the idea of hierarchy moving to relationship. And we're very intentional about how we onboard the people who work in our system to be able to function in that way. Next slide. So we think this idea of being in relationship, that is the core competency of our healthcare system. The thing that we are producing every day is improved relationships that exist internally between teams and infrastructure programs, and externally between the system at a micro level with families and at a macro level with communities. And we're doing that sort of all the time. Next slide. And that we have an intense focus on creating ways that we as leaders are collecting the input and the voice of customers and engaging customers in being the driver of how we are doing continuous improvement. And so Doug and I spend, hours and hours every week specifically in community engagement efforts, listening to tribal leaders, listening to health councils, understanding the perspective of people who are receiving care, and more importantly, understanding what's happening for them in their lives that impacts their wellness in order to think about how the healthcare system can partner in their lives. So next slide, please. So our story really is about whole system transformation that's based on understanding the perspective of customer owners and employees. Next slide. And being willing, so on the left is the old IHS hospital I went to as a kid, being willing to decide that that old model isn't okay, and that we're not just going to tinker around the edges and call it improvement, that we're going to reimagine the vehicle of healthcare to be something that is completely different. And we're going to do it not by being driven by our payers or what regulates us or our accreditation, but being driven intensely by the needs and voice of the community who receive that care. And then we'll figure out the legal and financial world behind it, but the intention is to design something very, very different that's based on voice of customer. So with that, I'm going to pass the next section to you, Doug.
All right, so we are going to get to system design specifics in a few minutes, but continuing on the theme of what underlies the difference for us. Next slide, please. The reality is that the current medical system is based on particular assumptions, a particular medical culture, and what's really distressing to us is no matter where we go in the world, so in single payer systems in Europe and Canada, Australia, New Zealand, Singapore, the medical culture is pervasive and drives everything regardless of the financial environment. So the idea that you get the money right and then somehow magically you'll get a great system is a false assumption. The other thing on money, just to say it here, is also the idea that you need to shape consumer behavior by co-pays, deductibles, and financial incentives and consequences is also false. In our system, no one pays any out-of-pocket costs. There's no co-pays, no deductibles, no out-of-pocket expenditure. And you don't have to have that to shape behavior by people on the receiving side. So money is misunderstood. the U.S. has managed to screw up the money side of things worse than anyone else ever in history. But even in single payer systems, the medical culture is pervasive and drives the design of the system, which is extremely unfortunate. As April has already said, this idea that centers of excellence, so medicine's obsessed these days with high reliability, protocol standards, centers of excellence, best practices, organ-specific and specialty and subspecialty things and so forth. The problem is, especially if you're a little bit older and complicated, you go to 5, 6, 7 centers of excellence, who's the coordinator, integrator, who's the coach, the mentor, who's the partner that pulls that all together and helps make sense of it and supports you in your journey. And it's the people least able to do that on their own who are in the population subsection that drives the majority of costs. I think everyone knows this, but 5% drive 50% of cost, 20% drive 80% of cost. Healthcare consumption is not evenly spread across people in society. Next topic, next slide. So just on philosophy, a couple more slides. So this is very simple, but I think it's extremely important. In a high acuity environment, so if I get hit by a car on the street, the EMS people do things to me, the ER does things to me, the operating room does things to me, the intensive care unit does things to me. That's high acuity, and the system has the power and control, and the patient, the customer owner, the family have relatively little control. But in the majority of healthcare these days, somewhere around 2/3 of the money and the effort and the staff are in the consequences of people living with chronic conditions. And in that environment, it's not whether we want it to be true, it just is true that the patient, the customer owner, family are in control of the majority of the variables and therefore the cost and the outcomes. So whether they pick up their meds, how they take their medications, whether they take all their medications, whether they have side effects and quit taking their medications, where and who they get advice from, it's all under their control. What they eat, how they sleep, tobacco, alcohol, drugs, how they relate to each other in family units, what they do with anger and frustration, exercise, sleep habits, all these things are under their control and drive somewhere between 80 and 95% of the variables that drive cost and outcomes for 2/3 of the costs and outcomes in healthcare these days, especially those things that employers care about: healthy, happy, capable workforce and the work environment. Next slide. So another way to say the same thing is this example from complexity science. If I stand one place and I have a bunch of rocks in my hands, I can eventually hit a target on the wall every single time. The rocks are passive. I can make them do what I want. I can best practice, benchmark, I can get coaching, I can measure, I can analyze, I can apply Six Sigma, Toyota production system theory. Eventually I can make the rock hit the target every single time. But if instead I have a live bird in my hand and I want the bird at the target, I can throw the bird with force and it'll go the way I want for a little bit, but then it takes control. It flies where it wants to go. And if the bird is attracted to its bird babies or bird seed or the telephone wires or trees, it's more likely to go there than my target, which may have no value or relevance to the bird. So this is healthcare, right? High acuity is like throwing rocks. They're passive, we do things to them. But as soon as they're in control, it's like the bird. The bird's gonna go where it mostly wants to go. So we have to either make the target we value attractive to the bird, or more importantly, we need to move our target to where the bird already wants to go. So just to give an illustration real quickly, if I have a 55-year-old Alaska Native man in my office, there's a 95% chance that he likes to hunt, fish, and berry pick. He likes to go back to the village he and his ancestors came from. He likes to take his grandchildren with him and teach them hunting, fishing, berry picking, and so forth. So if I talk to him about his diabetes as this hemoglobin A1C thing, we got to get it under control or surely bad things will happen. Here's some pills, take them, and he doesn't feel anything in terms of symptoms, it's unlikely he's going to do a great job of self-control with his diabetes. On the other hand, if I move my target to his values, if I talk about his eyesight for hunting, his fingertip sensation for fishing, his toe tip sensation for walking through the stream or the bog or the marshy areas, his eyesight for picking out ripe and unripe berries, now I've got his attention because those are the most precious values to him, and maintaining those over time because he wants to teach his grandchildren and show them how to perpetuate Alaska Native lifestyle and values. Now I've got his attention because my goal of diabetes control is connected to his goals of hunting, fishing, berry picking. I've moved my target to his target. Now he's interested. Now he's way more likely to do what he needs to do to get this diabetes thing under control and get his hemoglobin A1C down. This is me, the system, the medications, the instructions, the coaching, adapting to him, his values, his priorities, his goals, and so forth. It's a radical, dramatic shift of power and understanding. It means we're primarily in the business of influence and coaching, advising, and cheerleading, not diagnosis and treatment plans. In fact, our arrogance goes so far as to call people compliant and non-compliant. We see them, here's pills, do what we say, and then you come back and then we judge you compliant or non-compliant in our infinite arrogance, condescension, and judgment as the all-knowing, professional-centric, institution-centric medical people. It's offensive. It doesn't work well. Next slide. So one more way to say kind of the same thing is this is a Stacy diagram, again, from complex adaptive system theory. On the horizontal axis is variation. The vertical axis is agreement. High on the bottom, low on the top. So in medicine, we used to do the top right-hand corner, chaos, which is, trust me, I'm a doctor, I know what's best for you. And that means lots of variation and inconsistency. So for the last 30 years, modern medicine's tried to drive to the lower left-hand corner, protocols, standards, high reliability science, lean methodology, Six Sigma Toyota production system. And that's good for when you're throwing rocks. So with 1/3 of medicine that's procedural, we're doing things to you. You want high standardization, high protocolization, and adherence to doing that stuff. But 2/3 of what we do belongs in the middle here. Not do whatever you want. There's still best practices, but an area where we continually adapt to them. So lots of creativity, an allowing environment, experimenting, lots of dialogue, an obsession with outcomes, but a lot of flexibility in the methodology to get there. So we do what's called tight, loose, tight management. We're obsessed with philosophy, as April was describing. We're obsessed with outcomes, but a lot of flexibility how you organize your day and your team and your work to continually adapt to the other person. We need to provide services when, where, and how it works for them, woven into their life whenever they need access to us. For over 20 years, we've provided same-day access for anything you want, however you want to connect. So in person, phone, email, text, over 20 years. Let the system evolve however it wants to evolve. And even before COVID, more than half of our encounters on any given day were virtual and mostly asynchronous, and mostly team members doing things in response in real time as people have needs. All right, next slide. What this means is about, again, 1/3 of healthcare is a manufacturing model. We should look to manufacturing excellence. This is where we do things to people, surgeries, intensive care units, ERs, traumas. But in 2/3 of what we do, it is actually a service model. We need to benchmark and learn from service industries how to be in relationship, partnering, respect, respond to the other on their terms. Next slide. So structurally what we've done, and this is again the short version, April and I have very limited time today with you. So we've got the people in the middle, the customer, owner, and family in the middle. We have people who are available to them 5 days a week, all hours of the day, by whatever methodology you want, phone, email, text, video, immediate response from a primary care provider, case manager, case management support, medical assistant, and a behaviorist, all immediately available to you. Sitting right with them, and again immediately available to be pulled in whenever you want the additional help, is an integrated pharmacist, dietitian, midwife, already mentioned the behaviorist, and then what we call a community resource specialist or social worker. And every clinic has multiples of these who are available just to join in the conversation in whatever format is needed. And then across different primary care clinics, we've got co-located specialists who are also there just to help the generalists do outstanding work. And those include 4 psychiatrists, an HIV expert, a dozen midwives, pain expertise, a fellowship-trained pain doctor, 40-year experienced pain psychologist, a couple pain-oriented physical therapists. We have a palliative care physician. We have adult complexity experts, child complexity experts, and they're all physically in primary care. We're pulling expertise to where people already are. But again, we build relationship, trust, connectivity, and then you can do most of what you need to do virtually after that. These things called smartphones are the main way we communicate in real life. There's no reason that healthcare shouldn't be based on that platform. So access, relationship, high reliability, continually adaptive to you. coaching, advising, partnering. If we can't influence you to do something different than you were going to do, then we have not had any impact on your life. Diagnosis and treatment plan is not enough, and we should never ever use the word compliant and non-compliant unless we're applying it to ourselves. Next picture. There's a talk to be done about physical spaces. People need to be together, see each other, touch each other. We de-officed everyone over 15 years ago. No one has offices. There's no doctor's lounges, no doctor parking spaces. We have integrated care teams. We still have medical people, but it's all done in these physical environments that are very carefully choreographed and connected and designed. So there's a whole talk to be done around physical spaces and how we use that. In real time, this is like a ballet. So you have your primary care provider, you have all these other experts, they're talking to each other, connecting to each other around this person this, that person that. Here's a phone call, here's a text, here's a whatever. And less than half of our service delivery in any given day is actually in an exam room, although that remains an important part of what we do. And it turns out if you do this, that what really happens then is that the amount of visits plummets, but the amount of touches actually goes up. And we weave ourselves into their time and their services as they want and need us. In the classic system, you have to make an appointment, wait weeks to be seen, then go through a ritual when you come in. So by the time we see you, you've taken off of work, come across town, got transportation, sat in the waiting room, gone through a whole bunch of stuff. So by the time you see me, you want a lot. You want labs, you want x-rays, you want pharmaceuticals, because you've invested a ton in this conversation and encounter. If instead we have longitudinal relationship where you can connect to me all day, every day for anything you want and need, then a quick phone call, a quick email, you're willing to try some things that don't involve a lot of tests. So it turns out by running the system like this, back to what Lee said a long time ago, we're very expensive in terms of people in primary care, but we're very cheap in terms of total cost, because primary care refers 65% less, orders way less lab, x-ray, and pharmaceuticals and so forth, because we're in the business of relationship and influence, not test, prescribe. And with that, I'm going to throw it back to you, April.
I'm usually so good at not being muted. If you could go back a slide, please. I'd like to share just a couple of examples from the perspective of a customer owner about this picture of an integrated care team. The idea is that I'm sitting with my family in relationship with this group of people, and that there's no access barrier to being able to reach out and talk in real time. So example, I have an uncle who's got a pretty darn complex kind of medical story, and he became hospitalized in a different hospital. And the hospital attending physician wanted to change a prescription. And he has worked so carefully with his integrated pharmacist that he picked up the phone and called that person directly and said, hey, can I chat with you? So we know that that hospital visit is one where he's not in relationship, he's not sure he can ask questions, he doesn't really understand the answers. But if he can call his integrated pharmacist, he has a voice of someone that says, okay, let's talk again after you get out of the hospital, and let's bring you back in and let's regroup. Just one more story. So we've integrated, we often do whole talks on this transition of the team being purely medical to having these integrated behavioral health consultants that are master's level clinicians. We have integrated psychiatry, which isn't pictured here. And that has happened over the course of the last 15 years. And I have a story where one of my kiddos was on his way to a primary care visit. He's in the back of the minivan. He says, Mom, when we get there, can we talk to the BHC? And I looked at him and I said, okay, what do you want to talk to the BHC about? And he said, Mom, the kids are having sleepovers and I need to get out of this pull-up. And the idea is this master's level clinician has been in and out of his well child visits, has been talking with our family about the changes that we're going through as a family unit over time, so that my son knows how he can reach out when he has a challenge. That means we're breaking the stigma of access to mental health. And the goal is, and this ties, Lee, to something you said in the introduction, that my son, as he goes through his journey of life, if he struggles with addiction, if he's struggling with mental health, he knows how through his primary care model, he can access that first step of that same day real-time access to behavioral health with the ability for immediate support and referrals to other places in our system as needed. Okay, next slide. So lots of what we've been describing is that the job then of the people who work in our system becomes very different than maybe how they were trained to do it in school or how they did that work somewhere else. There's a lot of retraining to get to this idea of shared responsibility. Next slide. And that the idea that we want to understand the story behind someone's eyes cannot just be us expecting the customer owner to share. It also means that we as the healthcare system have to show up as our true and authentic selves and being willing to take off the structure of all those initials and be a person and share the story behind our eyes as well. Next slide. We do a lot of work with systems who are thinking about primary care teams and primary care team integration. This is a picture of where I think it goes wrong. If your system requires that all of the work be led by and go through the provider, you end up with the provider being the rate limiting factor of how much work the team can do, right? They're the pinch point in your system. And that, I think, is a problem that we see happening over and over and over as people are reimagining primary care. Next slide. So we've done lots of work around parallel workflows. So what are the things that people need on the top, and who is the team at the bottom that can deliver it? And how does that team function as colleagues with each other so that they can each, based on the unique expertise that they bring, deliver in real time the services that customers will need? So I can call up and talk to my case manager and say, I'd like a refill. My case manager can say, tell me what's going on. I'm sitting right next to the doc. Let me just put you on hold and see what he thinks. Come back and say, oh, you really do need to come in for an appointment. But they are working kind of collaboratively as a team to deliver maximally what the customer owners need through that collaboration that's in that healthcare team. Next slide. And the other thing we haven't quite said specifically is that each of those teams has this sort of panel of customer owners and families who they work with every day. They have a set of clinical outcomes measures that they're expected to deliver on for that specific panel of customer owners. That means primary care is not about who happens to call you today. It's about proactively knowing what the healthcare needs are of this mini community that your team is in relationship with, and reaching out proactively to bring that community in, whether that is virtually or by phone or in person, in order to be working through that journey in partnership. And we do balance, I'm going to say honestly, this idea of continuity, always seeing your own team, same day access for the last 25 years to your primary care provider and your nurse, with the fact that doctors and nurses take days off. And so we have this backup plan for being able to have access with backup providers that has to be in balance with this concept of continuity. Lots of work and thought have gone into that. Next slide is you, Doug.
So everyone wants to know how this works out money-wise. So just a little bit of time on money. So first of all, just size. We employ 2,500 people. Our sister company, the Alaska Native Tribal Health Consortium, employs about 3,000 people. So we're just shy of 6,000 staff, which includes then providing services across the entire range. So everything from water and sanitation services to clinic building and facility development, all the way up through primary care, women's and children's, behavioral health, and the hospital. We're a level 2 trauma center, a couple hundred beds, a NICU, PICU, ICU, CCU. So this is a vertically integrated system from community all the way through the high end of hospital. There's a very few things we don't do. We've got a Da Vinci robot. We do oncology. We don't do organ transplants. So there's a few very high-end things we don't do, actually anywhere in Alaska. Alaska has no organ transplantation, doesn't have a burn unit. There's a few things. But for the most part, it's a vertically integrated system. So we can see total cost around boundaries. The system as a whole, us to the consortium together, and then there's many other rural providers around the state that we support. As a system, as a whole system, The majority of our money is fee-for-service awfulness. So we do a service, we get paid. So Medicaid, Medicare, private insurance, fee-for-service. There's really no commercial managed care in Alaska. It's not a big enough market for commercial managed care interest, although the state is probably going to push that way. About 40% of our money comes through the Indian Health Service as essentially a block grant. By the government's own calculation, it's about 40% of what it takes to run a decent health system. So the Indian Health Service, woefully, embarrassingly underfunded. It's a racist policy against Alaska Native and American Indian people that should not be okay with us as citizens. Extremely poorly funded, but it is nice, flexible money. And then we have, we run 17 community health centers, so we get HRSA, community health center money, some VA money, disability money, and then also grants, research, and philanthropy. So we have a mixed revenue stream like most of healthcare does these days, some at risk, some not at risk funding. Our costs include everything. So we do a lot of residential treatment things. We do a lot of things on addictions, behavioral health. We include optometry, dental, all of pharmaceuticals, medications, all of the rehab, physical therapy, OT, PT. We also include things like complementary medicine. We have chiropractor, massage, acupuncture. We have tribal doctors in traditional healing. And this is all in our total cost package. So we're a very comprehensive service provider and comprehensive in calculating our total cost. And as best we can tell, across the U.S. right now, it's 10 to 11,000 per person per year national average. Higher risk populations, Medicaid and Medicare, between 12 and 20,000 per person per year. And we spend about $700 or $7,500 per person per year. So we're at more or less 2/3 of the national average and probably half of what it ought to cost us for our relatively higher at-risk population. The way we spend money is global budgeting and global system design. As April said earlier, we design the system to do the right thing. And then on the back end, we figure out how to make it financially viable. So our staff, there are no RVU requirements, productivity requirements. There is no pay for performance in terms of volumes and that sort of thing. We have a massively capable data system, though, and we track clinical outcomes, utilization rates, everything you want to know about running a good healthcare system, we can track. So global budgeting, do what's best, personnel do what's best, and then we kind of figure out on the back end how to make money. Next slide. What this means in terms of primary care is that if you look at our primary care budget, it looks very expensive. Small panels, tons of personnel. But most of these people were repurposed from somewhere else. So the behaviorists are a pure ad, but everything else came from somewhere else. So some of the specialists and the midwives and the pharmacists, they existed elsewhere. We just now located them in primary care. So we pull everything to where people are. We connect, after we have relationship and trust, we then connect virtually the majority of the time. Guaranteed same-day access for anything and everything you want by however you want to connect. And as a result, people will try things, do things that are less expensive. So we have way less lab radiology prescriptions, way less use of the ER, hospital, and specialty referrals. And if you do this, you give up a lot of revenue. So we lose somewhere between 20 and 30% of the revenue we could be making, tens and tens, if not hundreds of millions of dollars per year in our system as a whole. But it turns out if you drive down cost faster than you give up revenue, your margin improves. And healthcare seems to not understand this. But we think we've decreased costs by 30 to 40% while giving up 20 to 30% of revenue. There's a lot more to be said on this topic, but I just want to assure you we're very sophisticated financially, very successful financially. What we do is intense people, human things in a coordinated, all family, everything together way, and then pull in specialty as we need to from there. Certain specialties in primary care, other specialties by connectivity virtually, and then reorient the entire health system to this hub system that we've tried to describe in way too short a period of time. So down the home stretch, April. Next slide.
Okay, so Lee, I've got 3 quick wrap-up slides. The first is this idea that as much as we've talked about the way we design our system, we always balance that back to that the customer is going to own the system and we're going to be driven by their voice. Next slide. And that isn't a survey we do once a year. It's actions that happen, and these are some examples of them, continuously as part of the fabric of how our healthcare system works. Next slide. And we've now been recognized nationally and internationally for this healthcare redesign. There's something called a Baldrige Award. We're the only healthcare entity to win it twice. It's the big national award for quality improvement systems. We host a conference where we give this talk over 5 days. And at our conference, which is located up here in Anchorage, it's super interesting to know that most of our attendees are from other countries. What we're doing is far more about population health than it is about being driven by how you're paid, which is much of what the broken U.S. healthcare system looks like. And then finally, I just want to let you know that we think that our sense of identity, our confidence, and our pride is a driver of our wellness, right? And so we are going to say to Alaska Native people that this aspirational healthcare conference, all of you wanted to hear the story of Alaska Native people at your conference, and that what Alaska Native people have done to redesign healthcare is now a model for other people to be looking at. I just want to appreciate you for allowing us to do that. Thank you.
That was marvelous. If anyone who is participating in this, if your dopamine isn't surging right now, you have no heart. This is absolutely thrilling. Please put any and all of your questions into the chat. We're going to be addressing those live as they come in, and that should be open. And now let's hear a couple of things. One question that wanted to kick off here was, obviously what you represent is change, which is what we need. How much of the results are due to changes in the behavior of people, of your owners and your patients, versus changes overall just to the system itself?
So I'll start, and then Doug, you can add if you'd like. Lee, I think the crux of your question is this concept of behaviors, right? And you're kind of talking about both pieces of that, the behaviors within the system and the behaviors within community. Early in our story, when we decided the values that were going to ground the design of our system, the idea of customer ownership, the focus on being in relationship, breaking hierarchy, sitting in partnership, being designed by voice of customer, the first step in that really was to listen to customers, to know that's what we needed to do, but then to change the system within, right? So that the people who worked in the system were going to embody those values. That doesn't happen because Doug and I and people with fancy titles sit in boardrooms. It happens because 2,600 employees, about 5,000 if you include our cooperated hospital, come to work every day experiencing and feeling and carrying out those values. And that, when we were small, happened because of passionate leaders. And as we got bigger, happened because we developed the fabric of the organization such that you have to operate that way in order to do your work, right? People are physically spaced in that way. People are organized by teams. We hire based on those values. We onboard based on those values. So tons and tons of focus about knowing what you want your corporate culture to be, and then developing that culture to be how it plays out on the part of the workforce. Second part of that question was, what does that mean for behaviors within families? And I have a two-part answer for that. One is, when my grandmother got her care at the Indian Health Service, she was sort of afraid of anything that was the government, right? Alaska Native people didn't have a good experience with the government. I think that's true of people in healthcare, right? It's big, it's overwhelming, they don't have time for me, it's expensive, I don't want to go there. And so if you want to reorient the relationship between community and system, you have to prove it to people. That they're going to have, you can say it, but really it's about how people experience it. And so when you have a trusted friend in the healthcare system, right, whether that's your nurse or your provider or your behavioral health consultant, coach, and you can call that person anytime, and they're going to believe you, they're going to care about you, you start to change the orientation of community with system, and we see that happening generationally over time as we've walked through this journey. I'm going to pause there because I know I'm giving a super long answer.
That's great.
Okay.
Doug, anything to add to that?
I think we'll go on to other questions. Any topic you pick, April and I are capable of talking about 15, 20 minutes each one.
Okay. We, if you could go back in time to speak to yourselves 20 years ago, what advice would you give your past self who was early in this journey to help get there a little faster and to avoid any pitfalls or dead ends that you might have had to traverse?
So April, can I give my little lemon speech here?
Sure.
So people want to know, Lee, I'm going to reframe your question just a little bit. People want to know, what's the one thing we should do? What are the 1, 2, or 3 things we should do? Where should we start? And that's a very difficult question for us because we took an entire system and rebuilt an entire system from day one. And this is very, very difficult. You're flying in the face of the medical model. You're flying in the face of what everyone's been trained to do, including the community. So the staff don't get it. Management don't get it. The patients, the community don't get it. It took us 10 years to sort of retrain, redesign everything, including the community. We spent a ton of time sort of reformatting words and models and expectations for people on the receiving side, as well as on the sending side. This is very hard work. This is not some magic. In fact, we, so two quick things. One of the big funders of philanthropy, we went to them and said, hey, this is like 10 years ago. We said, hey, you tell everyone we are like the future of healthcare, isn't it wonderful? So we want some millions from you to do some really innovative, creative stuff. And they said, no, we're not giving you any money. And we said, but wait, you tout us to everyone. And they said, yeah, but you're like a pilgrimage site. People go to your place. They have this incredible, spiritual, amazing activity, and then they go home and do nothing. And we don't want to pay for spiritual pilgrimages. We want to pay for transformation. And the product you're selling is too difficult, so we don't want to fund you. I said, well, that's not fair, just because we did the hard work. Anyway, it's a difficulty because this is not a little patch. This is a fundamental rethinking of the basic assumptions of the entire healthcare system, and it's threatening to all kinds of people in the status quo. However, we are in a disadvantaged environment. So when we first started having success, people would say to me, well, Doug, why do you work in that terrible place? It's in Alaska. There's no professional training schools. Recruitment and retention is terrible. Alaska Native people, tobacco, alcohol, generational trauma. It's depressing. It's cold all winter. Everyone wants to visit Alaska. No one really wants to live there. You have terrible funding. You have terrible facilities. You're like the most hopeless place on the planet. Come work for us. We're doing cool stuff. Now that we're wildly successful, have won all these awards, people say, well, it's because you have these unfair advantages. Alaska Native people, they love their children. They have this culture of caring. And Alaska, who wouldn't want to live there? And look at your buildings. You must just be rolling in money. So you can do these things because you have the wonderful Alaska Native people. You have incredible recruitment, so forth and so on. To which I say, look, if we could make this good a lemonade out of the lemons we were given, shame on you for not making better lemonade from the lemons you have, because the lemons we were given were actually pretty terrible lemons. So we took something and took an opportunity and did something remarkable, and it's not perfect. Every day we disappoint people. Every day we frustrate people. We have so many big projects we're working on now to keep driving this whole thing forward. We have a very long ways to go, but we're quite confident it's a better thing. And no matter where we go in the world, employers and consumers tell us this is the way they want to go. It's the institutional people who are opposed to us. Many institutional people all across modern medicine, because we're very threatening to what they know, what they're comfortable with, and how they know how to manage and spend money. But it's time for this to happen. This has got, like you said at the beginning, and the people we're mad at often the most are primary care people who have accepted a watered down role in life, which is ridiculous. Everything, the center are the customer, owner, and family. Everything else needs to be reoriented to relationship, influencing, partnering, and every other part of the system needs to be responsive to that core mandate.
That's great. One question coming through here is how do your teams address mental health from a preventive and supportive perspective?
I love this question. I was hoping you'd have time for this one. Let me share something that's really cool. So we have a huge investment in shifting away from wellness being provided through medical intervention and really thinking about multidimensional wellness, right? And so my role prior to this one was the Vice President of Behavioral Services. So in that role, Doug and I worked together, medical and behavioral in partnership. I think it's really cool that a healthcare system, when the president CEO job is open, looks to behavioral health, right, the leader in behavioral health, to move into this role. So our investment in thinking about behaviors is gigantic. So if we say that in primary care, our competency is going to be for those teams to sit in real human relationship with families. And we're going to talk about our story and our journey and what's happening in our families. What's going to happen when you start to peel back those layers is you start to see more and more of the behavioral health needs, the emotional wellness needs, the spiritual wellness needs of people and families. And so we've done two things. One, we have created the integration that helps provide the real-time, immediate, brief intervention services that are appropriate in that primary care relationship. That has meant that we're raising the competency of all people who work in our system. So whether you are a dietitian or a family practice provider or a pharmacist, your job is physical, mental, emotional, spiritual wellness. And the integration of behavioral health raises the behavioral health competency of everyone on that team. The second thing is to say, if you're really going to start opening up those behavioral health conversations and provide real-time, in-the-moment brief interventions, there are times when people have needs greater than what can be done in primary care. And that's a tension for us to figure out. How much do we bring services into primary care relationship? And when is the correct thing to do to move services to specialty behavioral health? We have a pretty large specialty behavioral health continuum where we do residential children's services, outpatient children's services, outpatient addiction, residential addiction. We have a day facility for adults with persistent mental illness where we have, that is their primary care location. Their primary intervention is behavioral. We've reverse integrated medical into that environment. We have intensive case management and ACT team, and we're out in community. We run the clinics and the shelters in our community. So thinking about not just how do we do that within primary care, but when do we know that people aren't going to come to primary care and that we're going to interact with them in other places, and how do we develop the right interventions in those other places, which are almost always primary care or behavioral health based.
As for tools of reaching your population, is it, mobile app, or is it just good old fashioned text messaging to people's cell phones? And do we have to worry about having technological tools in order to be able to make this flow?
So privacy and HIPAA and all the regulatory agencies drive us nuts. And so what we do is we do the right thing, and then we figure out how to explain to the regulator how it meets their needs. And, and we've done that for decades. And it works very well, because it turns out what HIPAA wants, what Joint Commission wants, what everybody wants, what OSHA wants, is the same thing we want. So like HIPAA, it's everything about me with my consent. So as long as people give consent, you can share their information anywhere where they tell you that it's okay for you to share it. You just have to talk to them about when, where, and how you're going to use information and how you're going to share it. So all those integrated care team spaces are all HIPAA compliant. They're all privacy obligated. We don't have compliance, regulation, and privacy issues any more than anyone else does. I mean, there's people who violate it, who do stupid things. We have to intervene. But in terms of system design, we haven't created problems. What you have to do is talk to people, tell them what you're doing. Here's how the system works. Here who sees your information. Do you consent to this? Yes, I consent to this, and then you're good to go. So people over-obsess. They use HIPAA as a club to keep you from doing lots of good stuff, which is completely ridiculous.
Totally agree. It sounds like my relationship with HSA rules. I love the de-officing concept and the ballet, as you described it. What a great word to provide a concept around the integrated teams. Down in the lower 48, certainly we can add direct primary care and begin to establish the relationship and build the infrastructure. If I had a typical, and again, there's lots of different varieties, but if I had a typical direct primary care arrangement that has maybe some physical therapy, some behavioral health, maybe some social worker support, what should I build onto that? What's the spoiler and rims that I need to add?
So from what I know of direct primary care and its evolution, The problem with it is it's extremely doctor-centric. And if we're and often doctor exclusive. So I'm going to run a little private practice. I'm going to have subscriptions, and I'm going to run a super low overhead system. That's what mostly it is. We're the opposite of that. We're a super high overhead system. We got CMSs and CMAs and behaviorists and co-located specialists, coming, just running out our ears. The doctor does the minority of the work. If we're in the business of influencing people and partnering and cheerleading, doctors really, that's not what they're trained to do. They're trained to do diagnosis, treatment plan, and then judge people compliant or non-compliant in arrogant ways. I'm overstating for emphasis. But the biggest difference between the direct care movement and us is we're the opposite. So we participate in a national movement called The Office Visit is a Dinosaur. And if you take the average office visit and unbundle it, there's like 14, 15 component parts. And it turns out 12 of those 15 ought to be done by non-physicians in an asynchronous manner, which means this idea of the office visit. And then in COVID time, people just took the in-person office visit and virtualized it without really changing it, which is terrible. Because really what you want to do is provide services, knowledge, expertise, and support when, where, and how they want it. When, where, and how they need it and they want it. It means immediate availability by whatever form they want to connect to whomever they need. And you keep 2 or 3 people as the primary relationship, because you can't have intense relationship with 10 people, but you can with 1 or 2 or 3 people. And then they pull in people, coordinate, and so forth. And like April said, often it's not the physician you even want. So physicians are important, but they're the tip of the ice. Work at the top of your license is one of the most powerful mandates. Total cost is lower than most other people, but our personnel costs are very high because we're in the messy human business. We're not in the lab ordering, radiology, pharmaceutical ordering, and specialty referral business, which is what most primary care people think their job is. Fundamental redefinition. People want to be seen, they want to be known, they want to be in relationship with full access, and they want us to weave our expertise into their lives on their terms, when, where, and how they want it, period.
This is exciting. A very aspirational, which is apropos to the conference, but absolutely thrilling to be thinking about this. Already I've got ideas going in my brain. We'll see if I get anywhere with them, but my hope is basically, to not have this be a Mecca visit.
Lee, I think all we did was do what that driver of your Uber. All we did was do what that driver of your Uber told you they wanted done. That's
exactly right. You just did what. Of course, you did what we should do, because that's what we all want, right? Good relationship, trust, know the kids, keep it affordable. If something goes wrong, we quarterback it all the way through and make sure it's taken care of. Both of you, thank you so much for everything that you have done. And keep, but don't rest on your laurels. Keep pushing the industry further, because all of us lower 48ers, we're going to get there someday, and we need you to keep teaching us what's next. So appreciate you. And with that, we will begin going into our track sessions.